All right, so the next speaker is not with us, but will be with us by Skype, by teleconferencing, and that's Dr. Fred Lublin, who's the Saunders Family Professor of Neurology at the Icahn School of Medicine at Mount Sinai, and the director of the Corrine Goldsmith Dickinson Center for Multiple Sclerosis at that institution. Dr. Lublin is a neuroimmunologist who's had specific interests in the immune functions and abnormalities that affect the nervous system, including multiple sclerosis, among other illnesses. So it's great to have Dr. Lublin with us today, and I can see him on the screen, so welcome.
Welcome. Good morning, everyone. I'm sorry I'm not there to join you. I suspect it's nicer weather than where I am on the East Coast. What we're going to discuss this morning now is looking at multiple sclerosis and how we treat it, how we individualize our approach. And I should preface this by saying that multiple sclerosis is at the leading edge of the new field of neurotherapeutic. We have disease-modifying therapies, and that actually is a rather unique situation because most of the other areas of neurology have symptom management. But we're altering the course of the disease, multiple sclerosis, even though we don't actually know the cause. Let me have the next slide, please. My disclosures. Okay, next slide. Learning objectives. Okay, so you can see these. We're going to look at some of the clinical data, but mostly we're going to show you how we apply it to individual patients. Next slide, please. So, multiple sclerosis is an immune disorder of the central nervous system, meaning the brain, the spinal cord, and the optic nerves. We treat it as an autoimmune disease because the immune system is involved. We actually haven't proven all the rules of autoimmunity, but nevertheless it behaves much the same as other autoimmune diseases, except the target is the central nervous system. There are 4 subtypes of multiple sclerosis. The clinically isolated syndrome is the first attack of what's going to be multiple sclerosis, and that typically is an optic neuritis, a brainstem or cerebellar inflammatory event, or a partial myelitis. Relapsing remitting MS is the commonest form of the disease, where you have an acute attack and you have periods in between attacks where you may have impairment, but you're holding steady, then you have another attack. Primary progressive MS is the form of the illness which starts with gradual worsening instead of with an acute attack. And then some of those people may go on and develop attacks later on. This differs from the relapsing remitting form in that it tends to occur in an older age group and it affects men and women about equally, whereas I'll show you what happens with the relapsing forms. And then secondary progressive MS can result in those with relapsing remitting MS that after a period of time, some of them will go into a progressive phase where they gradually worsen in between the attacks. One of the things I should stress at this point is, of the serious neurologic diseases, MS is the most variable, from very, very mild to very, very severe. Next slide, please. So a little about epidemiology. It affects young adults, primarily between the ages of 20 and 40. Women outnumber men by a ratio of about 3 to 1. As I mentioned, most present with the relapsing remitting course, and the worldwide incidence of MS is increasing for reasons we're not clear of. It's not just because more people have MRI scans. Next slide, please. So, they took out my redlining here. Okay, they probably thought that I accidentally left it in, but I didn't. And so what I originally had done was crossed out to 450,000 because we recently reevaluated the number of individuals in the U.S. that have multiple sclerosis, and we used to use this old number of 450,000. It turns out there's probably about 1 million, and therefore the worldwide incidence is increased as well. As I mentioned, it affects women more than men, and Over the last 30 years, that ratio has gone from 2 to 1 to over 3 to 1, meaning that most of the worldwide increase that we're seeing in disease is occurring in women, and that increase is occurring too rapidly to be genetic, so it has to be something environmental. Now, in terms of disease course, MS doesn't impact lifespan very much. There's some studies suggest that it may shorten life by about 6 years, but that number looks to be shrinking as we apply our therapies. It does have an effect on quality of life because individuals have the illness for a long time and they may have considerable disability for long periods of time. And while I'll discuss with you disease-modifying therapies, we do have issues that they cost a great deal. And we're looking to see how we can lower those costs and even repurpose approved agents. Next slide, please. Okay, diagnosis of MS. So the classic diagnostic criteria is lesions of the central nervous system that are disseminated in time or disseminated in space. So on this slide, you see DIT, that's dissemination in time. That means more than one, a lesion occurring in more than one time. Dissemination in space means that the lesions involve more than one area of the central nervous system, and CIS refers to the clinically isolated syndrome. And so the way we diagnose MS, well, before we had MRI scans, we used to have an individual come in with a history of involvement of the nervous system at some point, let's say an optic neuritis, and then present with a partial spinal cord syndrome and have objective evidence of lesions of both those areas, and you would diagnose multiple sclerosis. Keeping in mind that every time we come up with diagnostic criteria, we always put in the caveat that there be no better diagnosis, because there's other things that can give you dissemination in time and dissemination in space. And so these are the criteria for diagnosing multiple sclerosis, but not differentially diagnosing multiple sclerosis. Now, if you don't have all the clinical evidence, you can take a person who's had a single attack, this clinically isolated syndrome, say optic neuritis or partial myelitis, and if on the MRI scan, you can meet criteria for dissemination in space. And that means having one or more lesion in 2 of 4 critical areas of the nervous system. I'm going to show you those on an MRI. You also can use the MRI to give you dissemination in time if you see on the same scan enhancing and non-enhancing lesions. Or instead of dissemination in time, if you do a spinal tap and you find oligoclonal bands, that is, bands in the spinal fluid of immunoglobulin that are not present in the serum, then too you can diagnose multiple sclerosis. Next slide, please. So here's the MRI scan. So MRI has been around since about 1981, and it's been extremely helpful for multiple sclerosis because prior to MRI, we had no imaging techniques. CT scans don't pick up these lesions very well at all. But the MRI is extremely sensitive to the lesions of multiple sclerosis, more sensitive than the clinicians are, which is to say there are 10 to 20 of these white spots that you see there that occur in the brain for every one that produces symptoms. And so I mentioned that there was 4 critical areas. And so starting from the left, there's periventricular, meaning it's abutting upon the ventricle. Cortical, juxtacortical, meaning either in the cortex or abutting the cortex. Infratentorial, in either the brainstem or the cerebellum. And the spinal cord. The spinal cord is particularly important because we sometimes see asymptomatic lesions in the spinal cord, and there's very few other diseases that will give you asymptomatic spinal cord lesions. But even more importantly, as you get older, you can get little white spots in your brain, but they don't occur in the spine, and that's why the spinal cord is a useful location for imaging in patients with multiple sclerosis. Next slide, please. How does one get worsened with MS? There's 2 ways. Clinically, there's either incomplete recovery from a flare-up or an exacerbation in the relapsing forms, what we call stepwise worsening, or the accumulation gradually of progressive worsening independent of relapses. Pathologically, we kind of, and maybe even as an oversimplification, consider the exacerbations to be an aspect of inflammatory disease, whereas the progression is more of a neurodegeneration. And I say it's an oversimplification because even in the progressive phases, there's some evidence that inflammation is playing a role. Next slide, please. So let's get into prognosis. As I said, this is one of the most variable of these serious neurologic diseases. And at the present time, it's nearly impossible to prognosticate for a given individual. But we do have group information that guides us. So here on the left-hand side, things that are better prognosis, Caucasians. So interestingly, Caucasians are affected more than any other racial group by multiple sclerosis. The disease is most prevalent in Northern Europe and North America. However, they do have a better prognosis than either African Americans or other non-Caucasian races who, when they do get MS, even though it's less frequent, tend to have it more severe. A monofocal onset means involving only one area of the nervous system when it comes on, as opposed to multiple lesions at the same time, which carry a worse prognosis. People whose initial symptom is optic neuritis or isolated sensory symptoms do better than those whose onset is either motor dysfunction, cerebellar dysfunction, or sphincter dysfunction. And then the lower the relapse rate in the first 2 to 5 years, the more likely you are to have a less severe course. And of course, the longer interval you go between attacks also is predictive of a less severe course. And fewer lesions on the MRI is a better prognostic indicator than more lesions on the MRI. More than 2 contrast lesions, more than 9 T2 lesions, and oligoclonal bands all carry a higher risk of increased disability. Next slide, please. Let's look at these predictors a little more closely, especially those in terms of prognosis. So older age, people with onset of older age tend to do worse. Males do worse than females, even though females get the disease more frequently than males. The males have a more severe course, as I mentioned, not of European descent. Low vitamin D levels are associated with a worse course. It's not clear. Vitamin D is an interesting element in MS. We see low vitamin D, and it's related to both prevalence and perhaps severity, but we don't know whether treating vitamin D would have a beneficial effect on the disease. Smoking, on the other hand, is clearly bad for MS. So it's not just that we considered it bad as a general health item, but in fact, people who smoke have a worse prognosis. They're more likely to go on to progressive disease. Those who start the disease as now I'm over on the right-hand side of the slide. Those who start with primary progressive MS tend to have more disability. Higher relapse rate leads to more disability. Shorter interval between attacks, more disability. Brainstem, cerebellar, or spinal cord attacks lead to more disability. Not recovering well from your early relapses also is a bad prognostic sign. And early cognitive deficits. Now, bottom left, MRI observations. Well, the more T2 lesions, these bright spots that you see, the worse the prognosis. Same thing for T2 volume. The presence of gadolinium-enhancing lesions indicates disease activity. And again, lesions involving the brainstem and spinal cord also carry a worse prognosis because those areas produce more disability. Gray matter atrophy especially is a bad sign. And on the bottom right, biomarkers. Well, we're looking for biomarkers. Now, I'll come back to this a little later on is how we're getting to that. But one of the areas we're looking at is the last biomarker there is the retinal nerve fiber layer as detected by ocular coherence tomography. And that's going to have some interesting implications for for monitoring patients over time. Next slide, please. So, predicting the course, again, on an individual basis, very hard, but motor findings are worse than sensory, polyregional worse than monosymptomatic. Early bladder involvement, which usually means spinal cord involvement, carries a poor prognosis, and not recovering well from an initial attack. Next slide. And here's an idea of how the MRI lesions affect outcomes. So what's being measured here is something called the EDSS. It's a scale we use for disability, where 0 is completely normal, 10 is death from MS. People at EDSS 3 have mild disability, while EDSS 6, 3 is the red bar, 6 is the blue bars, and EDSS 6 means they're walking with unilateral assistance, like a cane. And you can see the number of brain lesions is predictive of going to both EDSS 3 and, more concerning, EDSS 6. Although the time it takes to get there can be considerable. As you can see here, there is 20 years now that we have therapies. Next slide, please. What's the risk for imminent disease worsening in an individual? So, as I said, it's impossible to predict at the present time for a given individual. But we do try and get an idea of whether we think their disease is mild early on, based on those factors I just showed you, or more aggressive. What's the risk? The risk is that with any given attack, there's a 50 or greater than 50% chance of some residual disability being left behind. And so what we found in our clinical trial testing is, and I'll show you this in a better slide, is the earlier to treat, the better we do. Next slide. Let's build on this. Sorry, I hate builds. Keep going. I think it has one more. Let's stop there. There may be even one more, but we'll see. So this is the idea of a therapeutic window. And that is, the earlier we treat, and every one of our studies have shown this, including the fact that we went from treating established MS to treating patients with this clinically isolated syndrome, that is the first attack of what looks to be MS, when there are MRI changes that are suggestive of MS. And the earlier we treat, the better we do. The later we treat, the less likely we are to get a good benefit. So this has become one of our mantras, that in fact we need to treat early. Next slide. So how do we treat? So there's several different ways we treat. Disease-modifying therapies, therapies that change the course of the disease, that's what we're going to concentrate on here. But I'm not going to discuss, but understand that we do treat the acute exacerbations, and we usually do that with high doses of corticosteroids. We have therapies that enhance recovery from acute attacks, such as plasmapheresis. We have therapies that enhance function of partially damaged nerves, things like dalfampridine. We have symptomatic therapies, which I will touch upon at the end of this presentation because it's important. The things we're looking to work on over the next several years are therapies directed at neuroprotection, independent of turning off the inflammation that produces some of the aspects of the disease. We want to try and find ways of protecting the damaged nervous system with new molecules. And we're also studying repair. So we're doing this both molecularly with molecules that either enhance endogenous repair or limit those factors in the MS nervous system that are inhibiting the ability to repair. In addition to molecular approaches, we're also looking at stem cell approaches to try and enhance repair. This is all in its early phases. It's kind of exciting, but we have much work to do. Next slide, please. So how does one use the disease-modifying therapies? And I'm going to talk about this a bit more, but one is what's called step therapy or escalation therapy, as opposed to using more potent therapies initially what's sometimes called induction therapy, although people probably aren't using the term right, because if you're going to induce, then you want to have a plan for a maintenance therapy. And even for those that are doing escalation, a de-escalation plan, and those have not been sorted out just yet. Next slide, please. So here's induction versus escalation. So even though we're not very good at determining prognosis, we try and make an assessment when we first see the patient, and it's part of the decision-making process. It's only one part, as I'll show you. But nevertheless, in those that we consider high risk, we would tend to start with a higher efficacy agent to try and get a treatment response for some period of time, and then theoretically revert back to a safer agent, although no one has yet developed a clear, proven strategy in that regard. Escalation, you start with one of the safer agents that's been around for a longer period of time and look to see either clinically or by MRI whether you're getting a response, and if so, move to a higher, if you're not, rather, move to a higher efficacy agent. Now, what are the problems with each of these approaches? Well, with induction, as I said, we want to start early. You may put someone on a very potent immunosuppressive agent early on that they're going to take for a long period of time without necessarily knowing whether they need to be put at that risk. In terms of escalation, you may not be treating someone aggressively enough and they can build up disability while you're determining whether your escalating agent is having enough value. Next slide, please. So how do you choose therapies? Well, there's natural history studies versus unnatural history. So natural history is data taken from say, observational databases, long-term databases. And there's places that have a long history of taking care of multiple sclerosis, and they have these data sets. The problem is that there's no control over how they're dosed, what drugs they're given, and what was available at the time to figure that out. Unnatural history is what we see in clinical trials. The advantage of clinical trials is it's a homogeneous population. They're carefully controlled, they're carefully monitored, and everyone's getting the same assessments. The difference is that clinical trials tend to occur over a much shorter period than the natural history of the disease. There's lots of push these days for looking at more observational studies because you're taking advantage of, say, large data sets and data that's already out there and such. And they're okay, but they don't take the place of controlled studies. And they never will, because there's too many uncontrolled issues in observational studies that you can't control for. So observational studies, what are called sometimes real-world studies or pragmatic trials, are best used to answer questions that didn't get answered in a controlled, randomized controlled clinical trial. So a randomized controlled clinical trial may tell you that drug A is better than placebo or even better than drug B, but that was only for the group you studied. You then could potentially use other designs than a randomized clinical trial to say, well, what about if we tested it in older individuals or people with heart disease or things of that sort? Now, there are statistical corrections and analyses and adjustments that are made to try and balance out observation studies, things like propensity testing and such. But frankly, they're only good for balancing about the confounds that are known, and they don't identify the biases or confounds that aren't known or weren't considered. And generally, when looking at observational studies, bias beats statistics. Next slide, please. So how do we choose therapies? Well, the best way to tell if one therapy is better than another is to do a head-to-head trial in the same trial. That's hard to do sometimes, and sometimes impractical. Another way is to have a tracking arm in a study of an active agent, but that may be underpowered to answer any questions. The most common way it's done right now is by inference. Inference is looking at one study and looking at another study, and I'm going to show you in a minute the really big hazard with that. And probably the biggest way we choose therapies is that we have options. And because we have options, this is becoming more common. We have more to talk about. And I'll get into that further. Next slide, please. So here are the broad classes of disease-modifying therapies that we have. We have immunomodulators, we have anti-cell trafficking agents, and we have cell-depleting therapies. Now, if you look at the immunomodulators, they tend to have the best safety. And at least for interferon and glutarimer acetate, which is what GA is, we have long-term experience. The cons are only modest efficacy, and the interferons, glutarimer acetate, are injectables. For the trafficking inhibitors, they have better efficacy. The onset is quite quick, and they tend to be well tolerated. The cons are opportunistic infections. There's a long story that I don't have time to get into this morning about progressive multifocal leukoencephalopathy, which is especially relevant to the drug natalizumab, which, other than that, is an excellent drug. And we have risk mitigation strategies for dealing with that. But the other problem is the cells are still in the body. They just haven't been able to get to their target organ. And so there's an issue of rebound. So if you stop something like natalizumab, quite suddenly, the central nervous system active cells are right there in the bloodstream, and they now can cross the blood-brain barrier and get into the nervous system and cause rebound disease. And longer-term safety is still unclear. For the cell-depleting therapies, they do a job in depleting disease-causing cells. They don't have the issue of rebound, but there are issues with opportunistic infections, secondary autoimmunity, especially with alemtuzumab. They're more difficult to use, and we don't know how long we can use them. Next slide. So I stole this slide from one of my colleagues who I have great respect for, but he had shown this at a meeting which showed the relative reduction, ARR is annualized relapse rate, how many attacks you had per year, amongst several of our therapies. And he also looked at things like MRI activity, absolute reduction, et cetera, et cetera. And so can we advance it once more, please? I added this to the slide because when you make a slide like this, let me see the next one. And the next. Yep, X this one out too. When you make slides like this, it implies that you could read across that top line and say that natalizumab is twice as good as, say, teriflunomide. And that would be incorrect. The only way to know that natalizumab would be better than teriflunomide is to study them in the same trial. And so you should never compare across trials, because even when you try to duplicate a study, you often fail. Even when inclusion criteria are the same, because the population may be different, the healthcare setting at the time that the study was done may be different, even the disease can be different. Next slide. So what to follow once you put someone on that? Well, one of the things that's really important is to follow the adherence, because if individuals don't take their medication as you're prescribing it, it's not going to do the job you hoped it would do. That involves dealing with how the drug is administered, how often it's administered, what are the side effects, how about laboratory monitoring? Some of the drugs require extensive laboratory monitoring, even for years after you stop taking it. Another important metric to follow is disease activity. That would be things like the relapse rate, both the quality, quantity, and recovery from relapse, and do they develop progression as measured by EDSS is one of our scales, a multiple sclerosis functional composite is another scale, or even cognition. And you can look at disease activity by MRI. One of the problems we have is we don't have evidence-based guidance as to how much activity is too much. So we could look at extremes. You start someone on a medication. We tend to like to get a baseline MRI 3 to 6 months after therapy, and that becomes the baseline. And then the next MRI, well, if it had 20 new lesions, everyone would say, that's too much activity, stop. But when you start to parse it down, is one new lesion, two new lesions, is that enough to switch out of a medication? Not clear. Same thing with relapses. Is one relapse in the 2 years after you start taking medication too much? Well, not knowable just yet. Next slide, please. So we try to personalize treatment. So idea is to start early, most effective treatment appropriate to that individual. Have a plan for determining suboptimal responders, even though we don't yet have the data that could clearly define what a suboptimal responder is to the first therapy, or when to switch, and we'll come back to that. And those that you think are going to have a poor prognosis, which you can't guarantee, start with more aggressive therapy. Next slide. So making treatment decisions. Here are many, but probably not all, of the factors that are associated with trying to pick a therapy. And we do this with the patient. We do this jointly. So one of the things that we do when we're treating MS patients is that we separate out the visit where we make the diagnosis, which is enough to handle one visit, and then we have them come back for the discussion of the therapies. We may have them read up a little bit of information, but we don't like to do it at the same visit because it's just too much to deal with. So here, let's start with some of these approaches. First, evidence-based approach, and let's see if I can. No, I guess I can't control a pointer here. Okay, so evidence-based approach would be using a therapy that's been shown to be effective through a randomized clinical trial. We have many of those, so that's fine. Safety is an interesting one because we're always interested in patient safety, but we also have to understand patients are interested in safety. And while we have some people who come in and say, give me the strongest drug you have, this disease scares me, we also have people who come in and say, how long has that drug been out? And I'm a little worried about what you want to put into my body. And so they put safety first. That guides us in treating and picking the therapy for them. Tolerability, different people have different levels of tolerating. Convenience. We have some therapies that are given intravenously every 4 weeks, and others that are given several times over a couple of weeks and then not again for the next year, and some every 6 months. And people have different ideas what's convenient for them. Monitoring. Some of these agents require extensive monitoring of either blood work. We always have to monitor MRIs, and how frequently you monitor, and that also has an impact on individuals. Make sure to be able to follow the instructions and come back for the monitoring so they don't risk their health due to a side effect. Pregnancy issues. Our typical patient is a young woman who's getting started with family planning. We don't want women conceiving while they're on our medications, and so it's a big part of the conversation. When were you planning to have your first or your next child? And this will guide us because it turns out that multiple sclerosis tends to do better during pregnancy. There's an increased risk of flare-up in the postpartum period, but during pregnancy, there's a protective element. And so we discuss whether they should go home and start planning a family, or if we're going to treat them, usually we want to treat them for a year before they want to start to think about conceiving. And then there's some medications we're more likely to use in women who are thinking about becoming pregnant or may accidentally become pregnant than others. And so that's a big part of the conversation. Cost is a factor only that whenever we're using expensive medications, the insurance company that provides their drugs is the silent partner in the consultation room, because we may write a prescription for one drug and they may find out their insurance company wants them to take another drug and won't pay for the drug we prescribe. This takes up a lot of our time appealing these illogical decisions. We talked about patient preference. Physician experience always guides doctors in what therapy they choose. We hope they're experienced enough with all the therapies that that's not a big factor. And then mechanism of action, MOA, is important at times because you want to look to see if it's going to interact with any other comorbidities that the individual may have. Next slide, please. I talked about comparative efficacy, and this is a busy slide. You don't have to pay attention to individual lines. It's just that we do have some comparative efficacy. It's just not the kind of information that helps us enough in making decisions, because it's pretty obvious that there's certain drugs are going to be better than others. And it only works for efficacy. It doesn't tell us about safety. Next slide. So we don't yet have the tools to confidently predict individual treatment response. We have a pretty good idea how groups of patients perform. We could use more head-to-head comparative studies, but I don't think they're going to happen. We need longer-term data of safety, and we need biomarkers of treatment response. And we'll get into that in a moment. Next slide, please. So as we get more comfortable with the therapies, we are setting a higher standard for success in terms of preventing relapses, preventing MRI changes, and preventing disability. And there's this concept of the disease activity-free state, or what's called no evident disease activity. It's an aspirational goal. We're not there yet, but that would be the idea of eliminating all the activity, and that's what we're shooting for. We're not there yet. Next slide. And this was just some idea of looking at relapse rate, relapse severity, and recovery as producing levels of concern, whereas the more relapses, the more severe the relapse, or the more incomplete the relapse, the more level of concern we have in terms of relapses. Next slide. Similarly, with the MRI scan, the more activity we're seeing on treatment, the more concerned we are. And certainly 3 lesions per year would probably be a high level of concern. Next slide. We also can look at disability-based assessments. And frankly, the development of any progressive disability on therapy is a pretty good sign that you're not succeeding adequately, and you should probably switch your therapy. And that includes what's called the EDSS, but we also look at something called the time 25-foot walk, which is easy to measure on each visit and gives us a quantitative measure how people are doing over time. Next slide, please. But patients are very much involved in these treatment decisions. They have to be, because we're asking a lot of them. We may be asking them to give themselves a subcutaneous injection 3 times a week, or come in for an intravenous infusion every 4 weeks, or take medication that may make them feel unwell, because there could be gastrointestinal side effects, there could be flu-like symptoms. There's a whole host of different things can occur. So it takes us a long time to sit and talk with the individual, usually about an hour, to pick out what's going to be the best therapy for them, taking into all these issues of occupation, lifestyle, travel, vaccinations. We have to time those, timing of pregnancy, etc. So, and even postpartum breastfeeding. So there are many elements that we need to partner with the patient on with this. Next slide. Switching therapies is also complicated, and this is an algorithm, not the algorithm, in terms of going from one of those safer drugs to drugs that may have more potential side effects. But it just gives an idea of things that we have to think about as we monitor patients. And the important point here is that these individuals, you don't just give them a treatment and wish them well. You really have to monitor them very closely moving forward. Next slide. One of the biomarkers we're looking at right now is something called neurofilament light. It's released into spinal fluid and blood when there's damage to axons. And so we're now looking at this to see if it could serve as a marker of future disability, or as a marker of a therapeutic effect. We don't have an answer yet, but we should over the next couple of years. I think it's going to be a useful marker. Next slide. Oh, that's more information on neurofilament. Okay, keep going. I hate builds. One more. Okay. So I wanted to end up with a discussion outside of disease-modifying therapies, and that is symptomatic issues. So no matter where someone is in the disease, from very mild to very severe, there's usually things that disease has done to them that you can treat. And this is just to make their lives better. So we treat spasticity, we treat spasms, we treat tonic abnormalities, we treat bladder dysfunction, bowel dysfunction, sexual dysfunction. Fatigue is very common in MS. We try and treat that. Tremor is not common, which is good because we're not very good at treating it. Psychiatric disorders, depression is 9 times greater in patients with MS than is in the general population. But it's also greater in MS than it is in other chronic diseases, suggesting that there may be an organic basis for it. Fortunately, MS patients respond quite nicely to the usual therapies for depression. There's psychological disorders, there's cognitive issues. You can have pain both neurogenic pain and pain from disuse of a limb, skin care when people have really lost mobility, speech and swallow dysfunction. And we have a whole list of complications of our therapy that we now have to take into consideration as well. So care of patients with MS is really quite complex. It requires personalization. It requires the patient to be a participant in decision making. The happy thing is we have all these therapies. We have a pipeline that's full of additional agents. We're making great progress, and we still have a ways to go. But in terms of treating neurologic disease, MS is way up there at the top. We have the next slide. Goals. So early intervention in patients with MS offers the greatest opportunity for long-term benefit. We have to consider the benefit and risk profile when considering patient preferences. Next slide. One more. Right. These are my colleagues at Mount Sinai in New York who are part of the MS program there. And I thank you all very much for your attention. Okay, to get started on questions. Okay, so there's a question about the ratio of women went from 2 to 1 to 3 to 1. Epigenetics. Yes, one of my colleagues, Patricia Kasasha, just gave a lecture yesterday about epigenetic analyses in MS. And there's some very interesting epigenetic work going on looking at DNA methylation and other ways affecting cytokine expression and such. And then are higher powered MRIs useful? So standard now is a 3 MRI. We're using 7 experimentally. 7 shows us more lesions and makes it easier for us to see some of the typical aspects of the lesion, but it's not entered into full clinical use yet. Now there's a question about cognition. So we're testing cognition now annually on all of our patients because cognition is impaired in multiple sclerosis, and we're starting to follow it. And I already talked about depression, treatment choices for cognition. We try and use medication for multiple purposes. For example, if someone has depression and fatigue, then we might want to use a more activating antidepressant in that individual. We don't yet have good therapies for cognition, and of course, depression impacts on cognitive behavior. And then there's a question here about Epidiolex and MS. So not so much CBD. So the CBD THC combination is approved in Europe for the treatment of spasticity in MS. And in Canada for treatment of pain in MS. We'd like to test it here to see if we can utilize it. Can we move down on the questions so I can see more? Diet. Okay, so diet is a sort of a black box right now. There's lots of nonsense on the internet. People can write books, but there's no data. One of the things that we're looking at to get a handle on diet is what's going on in the gut microbiome, because we think we need to know that before we can actually figure out what aspects of diet are going to be beneficial with patients with MS. That's all the questions I can see. Jan, are there any others?
That's good.
Are we good?
Yep, I think we are.
Okay, well, thank you all for your attention.